Well, good morning, everyone, and thank you for being here. Since CVS Health began as consumer value stores in 1963, we have continued to innovate, change, and grow. But our commitment to our customers, patients, clients, and the communities that we serve has never wavered. That includes our decision in 2014 to stop selling tobacco products and our ongoing efforts to fight the opioid epidemic. It is also what led us to the introduction of a whole new way for consumers to access health care locally. A demonstration of this new model is currently being piloted in Houston with the introduction of our new Health Hub, which offers a broader range of healthcare services, wellness products, trusted advice, and personalized care, all with the ease of walking right into a local CVS pharmacy. But we all know that one of the biggest challenges facing healthcare consumers today is the affordability of prescription drugs. For example, our data tells us that when medications cost patients over $200 in out-of-pocket costs per prescription, more than 40% of patients do not pick up those prescriptions. Each year, patients not taking their medications results in nearly $300 billion in unnecessary medical costs to our healthcare system. The status quo of increasing drug pricing is not acceptable, and yet we've seen no evidence of drug manufacturers' willingness to lower prices. In fact, we've seen just the opposite. From 2008 to 2016, brand drug manufacturers increased list pricing by, on average, 9.2%. By negotiating discounts and encouraging the use of lower-cost, clinically appropriate medicines, pharmacy benefit managers mitigate the effects of these price increases. In 2017, for example, CVS Caremark kept drug price growth nearly flat at 0.2%. Data clearly shows that there is no correlation between manufacturer-driven price increases and drug rebates. In fact, list price is increasing faster for drugs with little competition than it is for medications with competition and substantial rebates and discounts. With the rapid growth of patients enrolled in high-deductible health plans, there is a great demand for transparency when it comes to the cost of prescriptions. And we have pioneered several approaches to bringing transparency to those consumers. At the doctor's office today, we make real-time benefits information available. So when healthcare providers are writing prescriptions electronically, we can provide them information on patients' covered benefits and what patients will pay out of pocket under their plan for that specific drug. At the same time, we show the doctor up to 5 lower-cost, clinically equivalent alternative medicines that they can choose from for that patient. This tool is also helping to identify savings opportunities at all CVS pharmacy locations and for consumers using the CVS Caremark app. For a senior with heart disease, she can save $120 less, pay less than $120 per fill by using this real-time benefits capability. And if she does this for 2 of her 5 medications, she could end up saving nearly $3,000 each year. We've also seen that using a preventive drug list to make medications for common chronic conditions available at $0 copay can lead to better adherence and a 150% return on that investment. For example, a company that invests $6.2 million in providing first-dollar coverage for generics and insulin could see savings of $9.4 million as a result of medical cost savings and increased productivity gains. Also, we have pioneered the use of point-of-sale rebates and started by offering it to our own employees. As a result, we've seen adherence improvements of 4 to 6%, and today, 10 million people are covered by Caremark plans that provide this benefit. Just yesterday, we heard from CEOs of 7 major pharmaceutical companies testifying before the Senate Finance Committee. When asked about the high prices that they alone set, they deflected blame to others, and in particular, to PBMs. The truth is, drug manufacturers raise prices. PBMs negotiate lower prices. Brand drug manufacturers work to avoid, delay, and block competition. PBMs promote it. Pharma says rebates negotiated by PBMs are responsible for high drug pricing. But PBMs pass along these savings and are responsible for keeping overall drug spending nearly flat. Drug manufacturers spend more on lobbying than any other industry in this country. They do this by championing policies that lead to windfall profits and opposing those that actually promote competition and bring down costs. Let's look at specialty drugs and biosimilars competition as an example. Specialty drugs made up 46.5% of net spending in 2017, up from 24.7% in 2008. Why is it that in Europe there are 53 biosimilar products available on the market at a fraction of the cost of the branded specialty product, but in the United States there are only 7? It is because of the manipulation of the patent pricing and system to prolong exclusivity of the branded specialty product, as well as a series of roadblocks preventing FDA from moving forward with biosimilar approvals and creating a pathway to the interchangeability of biosimilar products. Take two as an example the recent proposal to eliminate negotiated rebates in Medicare and Medicaid. When it comes to addressing high drug costs, this proposal takes us backwards, not forwards. According to the analysis by the CMS actuary, if enacted, the majority of beneficiaries would see an increase in their total out-of-pocket payments and premium costs. In fact, some estimates suggest as many as 70% of beneficiaries will be worse off if the proposal is finalized. The CMS actuary estimates that premiums will increase by 25% over a 10-year period, and data shows that seniors are exceptionally sensitive to premium increases in making enrollment decisions. Pharmaceutical companies who have enthusiastically endorsed this proposal would keep 15% of the rebates currently negotiated. This while also benefiting from a windfall of nearly $40 billion, according to the administration's own actuaries. And all of this leaves taxpayers on the hook for a nearly $200 billion price tag. To be clear, rebates are not the reason drug prices are high. Drug prices are high because manufacturers use their monopoly power to keep lower-cost generic alternatives from entering the market. Anytime pharma spends over $200 million in an orchestrated campaign to smear and undermine tools that control costs, the American public should be very wary. So here's what rebates actually do. Rebates are discounts negotiated by PBMs and passed along to plan sponsors, including employers, health plans, and federal and state governments. And at every level, these rebates are being used to buy down cost increases in premiums to benefit consumers in accessing coverage. While drug manufacturers would have you believe that PBMs are retaining these discounts, virtually all rebates and discounts are passed back to our clients. For Medicaid and Medicare Part D plans, 100% of the rebates are passed through to help lower premiums, which reduces costs for the beneficiary and the government. In a world without rebates and the tools to drive discounts, prescription drug pricing will increase and escalate for states that are already operating with tight budgets, taking funds away from top priorities such as funding schools and investing in infrastructure. In fact, under the proposed rebate rule, drug manufacturers would have to voluntarily drop list prices by 45% to ensure that patients are held equal to where they are today. Yet we heard no commitment from the drug company CEOs testifying at yesterday's hearing that they would be willing to do this. So where does this leave us? First, we have a system today where PBM tools and capabilities are driving substantial discounts from Medicare, federal, state, and local governments, employers, unions, and health plans. But we still have a substantial number of pharmaceutical products that have limited to no competition because of the myriad manipulative practices in our patent system that prevent competition from coming to the market and restrict FDA from advancing policies that can speed adoption of biosimilars. And because of the rise of high-deductible health plans, the significant discounts being driven are not being seen at the pharmacy counter by consumers when they're in their deductible phase. So as our panel today considers solutions, I will offer several for consideration. First, Medicare should drive the adoption of real-time benefits to give consumers and physicians transparency at a lower cost and offer an option for a point-of-sale rebate Part D plan. Second, for plans associated with health savings accounts, policymakers can take immediate action today to change IRS rules to allow those plans to provide first dollar coverage for drugs outside of the deductible, even for maintenance medications intended to treat an existing chronic condition. Third, by prohibiting pay-for-delay agreements and passing the CREATES Act to stop REMS abuse, we can curb anti-competitive practices and help bring lower-cost, clinically equivalent generic medications to market more quickly. And fourth, biosimilar drugs have the potential to save the health system $54 billion over the next 10 years. But our country is far behind in accessing these medicines. In Europe, 53 biosimilar medicines have been approved. In the US, just 17, and only 7 of those 17 are on the market because of ongoing patent challenges. Finalizing interchangeability guidance will help bring real competition to today's expensive biologic drugs. Now, each of these recommendations create a funding mechanism to help solve other top priorities, like addressing a fix to the catastrophic phase in Part D. We at CVS Health will continue to innovate and use every tool at our disposal to bring down costs for our customers while also advocating for effective policies that increase access to affordable medications. Thank you for being here today for this important discussion.